All we have is a picture of my great-grandmother's gravestone. She was born February 2nd, 1902. She was a wife, she was a mother, and she was a teacher. And she died September 20th, 1925. Her death certificate says that she died by pneumonia. However, it was likely second to sepsis, an infection that was caused by an abortion. Her married last name was Chendalan. However, that does not show up on her gravestone. There's been many stories in our family as to why that may have come to pass. However, what we do know is that she was a young mother with 2 children under 2, at a crossroads of her life, and pregnant with her 3rd. Why am I telling you this now? Because you need to hear about it now. Because there's nothing new about the under-resourcing and underfunding of women's health care. For hundreds of years, women's health care has needed more investment, more research, and more innovation. It wasn't until 1993 when we actually had laws put into place where women were included in clinical trials. In 1977, the Food and Drug Administration actually had a policy put in place where anyone of childbearing potential was not included in research trials. And it wasn't until 1983, with the creation of the Health and Human Services Task Force of Women's Health, that we actually started looking at whether medication worked the same as in men as it does in women, and whether life-saving medication was just as effective. Knowing this history, it probably doesn't come as a surprise to anyone that maternal mortality, which is the death occurring during pregnancy or the first 42 days after delivery, has been a pressing public health issue for decades. So let me be specific. 9 out of 10 deaths that occur during this time period are preventable with evidence-based medicine. According to a recent research study that was out in March 2024, the United States actually has the worst maternal mortality of any industrialized nation. We are behind the UK, Sweden, New Zealand. That study was published in the American Journal of Obstetricians and Gynecologists. And that put the death rate at 10.4 out of 10,000, or 100,000, excuse me. The other issue that we see is the Black maternal mortality rate is much higher than the white maternal mortality rate. Black women die at a rate of 3 to 1 that of white women, and marginalized communities have a significantly worse history of pregnancy outcomes. We need to stop seeing women's health as anything other than a public health issue. Whatever political, legal, or ethical concerns we may or may not have, we need to make sure that healthcare providers are empowered to provide life-saving, evidence-based care for patients, and that patient well-being is the primary decision maker for care. There is more urgency now because people are suffering needlessly. While this has always been the case, the healthcare system in the United States has undergone a significant shift in the last couple of years. We are also seeing physicians leaving states where they don't feel safe practicing. This has created deserts of care, which in turn has made things worse for patients. Pregnancy has always been risky. There's gestational diabetes, blood clots, high blood pressure, preeclampsia, which is a high blood pressure issue that can actually affect other organs. We know this, and physicians need to be ready and willing to make sure that they're safeguarding the health of their patients and their babies. We've always been aware of this issue. However, we've been continuing to take steps backward. Patients are sicker, and yet physicians are leaving these states. In Georgia, half the counties do not have a working OBGYN. In Idaho, 25% of their OBGYNs have left. So what can we do? What can any of us do? It's tempting to give up, right? But we must not give up. To combat this crisis, we need a comprehensive strategy. First, we need to make sure that physicians are safeguarded and that they are able to practice evidence-based medicine without fear of legal prosecution. Second, we need to make sure that patients have access to comprehensive prenatal care, because if they don't have access to comprehensive prenatal care, pregnancy becomes innately more risky. Third, we need to make sure to educate the general public about the laws in their states. And we also need to make sure that we are encouraging people to rely on trained women's health care experts instead of other means of getting information. And finally, we need to make sure to advocate and amplify the voices of the people that are most affected by legislative changes and work hard to get policies in place where patients are focused at the center of decision-making and taken care of. It's hard to know how my family's story would have turned out if my great-grandmother would have gotten the care that she needed, if my grandmother hadn't essentially been orphaned by that abortion. And it's too late to ask these questions, but it's not too late to start envisioning a future where patients of every race, no matter what state they reside in, have access to that evidence-based care to make sure that they are safe. I want you all to do something for me. I want you to imagine a future where every physician, every patient, every nurse can make decisions based off of medical necessity, and medical necessity only, where fear is not a factor. This should be entirely possible, and it's the world we all deserve. However, it's going to take all of us. We need to work together to create a healthcare system that is patient-centered, that is equitable for all, and that is accessible for all. We need to create an environment where people have access to prenatal care, where physicians have bias training, because unfortunately we are the product of our environments, and sometimes those environments are harmful to patients. We also need to make sure that we are safeguarding physicians so that they can practice evidence-based medicine without fear of prosecution. And that's a future that I wish my great-grandmother could see, and that I hope for my children. Thank you.